since we used a lot of time, but it was quite interesting. And we appreciate you, Doreen Kopsinje, for that insightful and triggering discussion. And we recognize your competence and your grace in answering the questions. We have our own, who has been with us since Monday, Professor Howard Stein, taking his lecture this afternoon. Howard, you have the floor, and we also appreciate you for the continued energies and support towards this summer school. You have the floor, Howard.
Pleasure to lecture yet again to you guys. It's very challenging after two absolutely wonderful presentations, and it's always dangerous. It's always dangerous lecturing when people are eating lunch because they have things they can throw at you if they don't like it. So please be kind, and I'm pretty quick and I can duck, but maybe not quick enough. So let me start on another subject which I hope won't give you too much indigestion, because it is talking about, after all, wealth and health, and good nutrition is a very important part of that. And what I want to talk about today is something which is extraordinarily important in terms of the actual manifestation to basically mortality and morbidity, and the enormous unevenness in the world we still have between particularly African countries and the rest of the world. And so I'll go through quite a bit of that, wearing my epidemiology hat today. What I will plan to do is to kind of give you a case study. I think one of the things that's important for teaching is to be able to read fairly technical statistical studies, and then I'll try to sort of present the heart of it and understand them. And I found a very good one. Often I try to teach this stuff to my graduate classes, which actually does directly look at the relationship between maternal health and wealth inequality. So I'll be looking through, talking about what I call it the health divide. What is it that grabs our attention in real terms? And then look at the definitions that we mean by health inequalities, the health and wealth inequality conceptual dimensions, the way we have to go beyond surface analysis to understand the driving forces, and then the case example, and then finally talking about one way in which we avoid the enormous inequities which are embedded in wealth inequalities as it gets manifested to access to social goods with something called health for all, and what the implications are. So let me start with the health divide. And really, the greatest health divide in the world between the rich and the poor, between the wealthy and those with no or little wealth, is a product of the socioeconomic burden of mortality and morbidity. And there has been, for a whole variety of reasons, really global progress. It's remarkable how the global progress, a lot of it has to do with technological change, advances in medicine, but also advances in systems in places. So we look at the extraordinarily expansion of life expectancy from 46 to 65 years through the 1950s to 2009. That's just amazing. We've never seen this kind of growth in life expectancy in the history of humanity. And all the way up then to 73 years in 2019, but following, of course, to 71 years, 2 years later after COVID hits. But the problem is that the progress has been very uneven. We have a period in sub-Saharan Africa associated both with the AIDS epidemic and the absolutely atrocious impact of neoliberalism on healthcare for people, with actual decline of life expectancy from 1980 to 2003. We really don't see these kind of rapid declines very frequently. also in the Russian Federation as a result of the transformation. And what we had, of course, was the biggest was on the male side for a variety of the kind of social dislocations caused by moving from a socialist communist system into a market system, which was very difficult for people to adopt, as well as the transformation of accessibility of healthcare during that period. And we look in the case of individual countries in sub-Saharan Africa, we find that, for example, South Africa fell from 63 all the way to 55 years between 1990 and 2009 before rising to 66. And then falling again through 2021. Swaziland went through an extraordinary decline, largely because of HIV, between 61 and 49 over the same period, then back up to 61, then drop into 57. Even Botswana, one of the more developed countries in Africa, fell as a result of the HIV crisis mostly. So we go through, I don't want to go through all of these, it's very widespread, it's very inclusive. It's not just in South Africa where the HIV/AIDS was focused, it was other parts of Africa where we have much lower HIV/AIDS incidence. And so what we find now, which has been a pattern now for many decades, the countries with the lowest life expectancy are still in sub-Saharan Africa. Basically, under 60 years, the figures from 2021, 11 of the countries all in sub-Saharan Africa. The interesting thing is to look at the long-term movement of life expectancy from 1770 to 2021, really an extraordinary rise in a period, basically a comparatively late period for a number of countries, you know, after sort of, as we talked, the 1950s or so upwards. But I think what is quite noticeable here is the gap is still there. The gap between Africa and the rest of the world, particularly Europe, is still there. And the gap is really, 2014, if we just look at the gaps, again, gaps are inequality, right? This is one mechanism of inequality which we may see manifested. As I often tell my students as a development economist, we can talk about GDP, you know, you can talk about structural change, but often real progress is measured by life expectancy. And it's declines in morbidity and declines in mortality and increase in the quality of life. Because ultimately that is the basis of progress for humanity. Being able to live a long, fruitful, and healthy life is what we really should be aiming at. And the gap basically was 26 years in 1990, 22 years in 2014, and 19 years 2019. But the key here is it's not just looking at these averages. What is the richest country, the best countries, the highest expectancy to the lowest? And to think about, say, looking at the data in 2023, the highest being Hong Kong, the lowest being Chad, what kind of world do we live in that we, on average, allow human beings in a country to live 32 years less than another human being in another country? It's a disaster. It's inexcusable. It's unethical. It's inhumane. And it's something that has to change, basically. And that's one of the issues that's always driven my interest in epidemiology and public health relative to being a development economist. And you can see this here. I don't go through it. You just see the countries very high in one end, very low in the other. Again, unfortunately, mostly in sub-Saharan Africa. One of the ways you look at this is saying, okay, what are the causes of mortality? This is often what I use to examine what in essence are the challenges that exist where we have to overcome the burden of disease, and is it possible to overcome that burden of disease? What you see here in the yellow and blue, and it's always nice to see visual representations of this, are what I call totally preventable diseases. How do we know they're preventable? Because they do not exist anything near that level in the developed world. And so you can see the vast majorities of what I call preventable diseases are nutritional deficiencies, neonatal disorders, neglected tropical diseases, diarrhea, HIV/AIDS, tuberculosis, etc. And we see that that's reducing over time between 1990 and 2010. And one of the ways but it's still overwhelming. See, again, it's love to look at colors. You know, it's kind of, you know, it's with your young children, you can say, hey, look at the color. What does it mean? So the colors really mean something here. And the colors that are all this pinkish, reddish color are all basically preventable diseases. We see in 2019 in the low sustainable development, this is the way they categorize it, countries, we see neonatal, diarrhea, malaria, etc. And we look and we say, okay, why can we say those are preventable? Because you look at the developed world, the high SDI, what do you see? Where's the little red zone, guys? It's that tiny little zone up in the corner. This has been the transformation from a health perspective. In essence, what it is, it's rising, the kind of lowering of infectious disease, maternal diseases, which are preventable with the transformation of your socioeconomic system. And the rise, of course, of a lot of other what we call chronic diseases. And chronic diseases are not just diseases which come with age, they're diseases which come with environmental conditions. And you can see here, just looking at the figures of 2000, 2019, we look at the change of the various categories. So we look at what I call the cumulative maternal, perinatal, and nutritional conditions, basically, and we can see that it's quite small. And we look at the figure in the high end of the higher income economies, it's only 6.6%. And what it is in the low income economies, it's overwhelmingly, in 2019, 46.8%. But at least it's down from what we saw 19 years earlier, which was roughly 65.4%. So we're seeing some progress in there. Sadly, what's happening also is we're having a rise in chronic diseases. We're getting what we call, in Africa and other countries, the double burden of disease, which is in fact then rapidly rising chronic diseases, which is supposed to come mostly with age, but also associated with deteriorating environmental conditions. And so a lot of these preventable diseases are linked to the dynamics of socioeconomic development and transformation. We always have to be looking at the divide, as I said in my earlier lecture, globally, and the divide within countries, and what drives that relative to wealth. You can see here, 2019, the causes of death. What you find is something that didn't exist beforehand in causes of death, which is the rise of heart disease and stroke, now showing up, and road injuries, as we know too well living, those who have spent a lot of time in Tanzania and elsewhere, very high levels of road injuries from buses and otherwise, as with roads which are not sufficient for the traffic. And so we see this kind of increasing recognition of that. And you look at the top categories way back in 2000, and those aren't really present. So there is something going on, understanding what's occurring, we'll try to explain to some extent. And so one of the things that we'll look at in detail is something which is the biggest divide in the world, which is your maternal mortality divide. It's huge. And we look here at the figures, basically in, say, 2000, the rate is roughly 878, per 100,000, and we look at the developed countries, more developed regions. In 2000, it's only 16, and we do see some catching up. But you can see if you look at those ratios, you're roughly looking at, roughly speaking, something in the area of 40 plus to 1. That's a massive divide. You don't see that in age. You see this in terms of the maternal mortality divide. And it becomes an interesting thing to actually examine and try to understand what that relationship is, it will, in the study to wealth. So the question is, well, how do we look at this conceptually between health inequality and health equity? And it's important sometimes to begin to look at a definitional representation of this, basically, which has practical consequences. And what we have typically is health disparities, health inequalities, which can be measured, right? And then health equity. So health disparities and inequalities are defined as differences in which disadvantaged social groups systematically experience worse health or greater health risks than more advantaged social groups. And Whitehead, one of the early definitions that was kind of pretty much set the early tone in conceptualizing is basically, he argues, health disparities are differences in health that are not only unnecessary and unavoidable, but in addition are considered unfair and unjust. And so you have health disparities include differences between the most advantaged groups and all others, not only between the best and the worst off group. And then you have health equity, which is really, in some senses, your elements of ethics. So it's the idea with health equity that everybody should have a fair opportunity to attain their full potential. No one should be disadvantaged from achieving that potential if it can be avoided. And we'll see it very much can be avoided, and we'll show that empirically. Health equity then is all about equal access to available care for equal need, equal utilization for equal need, equal quality of care for all. Health inequalities then are the differences in the health between people, which is manifested arising from the position of socioeconomic hierarchy, including wealth, health inequalities by gender, and less frequently by ethnic group or national origin. So health disparities then can be seen as systematic, potentially avoidable differences in health or in the major socially determined influences on health between groups of people who have different relative positions in social hierarchies according to wealth, power, and prestige. Because these differences affect the health and health risks, that is to say, it's construed here as exposures or vulnerabilities, if you like, increasing the likelihood of ill health, or the social consequences of ill health. And basically what we have then is that link by virtue to where you are in your social positions. And so if we look at a kind of systemic understanding of this, what we're looking at, the health disparities which are linked to differences in income, wealth, education, occupational character, residential location, rural versus urban, race, tribal positions, religious, national origin, gender, and of course, absolutely crucial, as we emphasized for the first lectures, the impact of power, wealth, or prestige, everywhere also, divided through age, sexual orientation, and disabilities. The key really here is that health inequality is a measurable mechanism. We've been improving our understanding of this, and it really can give you a sense of the degree of unevenness that exists, and whereas equity then is your social justice statement. Question is, what is this link between inequality of wealth and health? And so two of the kind of common ones in the literature are the differences between psychosocial interpretations and neo-material interpretations of this divide. Psychosocial kind of reads to psychoneuroendocrine responses, which are stress-induced behaviors such as smoking, alcoholism, poor civic participation, less social cohesion and capital. And it's the idea that your position of inferiority in society leads to a related stress mechanism. Basically, your hierarchy itself leads to positions of self-degradation that actually then leads to health implications to you. And so, so the focus is more on perceptions rather than structural causes or material effects. And they argue then after a certain income level, neo-material disparities are not enough to explain health inequities. Clearly, though, it's not the case in developing countries, which leads us, some senses, to second interpretation. And I'd argue, of course, some would argue it's still very present, the neo-material in the developed countries, as we watch the United States of America having enormous differentiation of mortality rates by your socioeconomic category and county and by your race. And we can see this in terms of, I've given a lot of lectures of the impact of COVID, enormous disparities in how COVID hit, depending on your socioeconomic status in the United States and elsewhere. So we look now at the neo-material interpretation of inequality, and it really has to do with the differentiation of exposures and experiences due to a lack of material resources. It's the idea that you're systematically underinvested in human infrastructure with implications to those that do not have access to that infrastructure. And in some senses, it's very much linked to the larger economic and political processes which actually generate income inequality and wealth inequality. So the idea simply is that inequality itself generates health inequalities. And health inequalities can be reduced by improving the material conditions and the way that the material conditions are distributed and accessed. And so we have, in some senses, a rejection of this. In some ways, it's a bit of a superficial analysis. It becomes very important, as Jakob and others had argued, to go beyond the superficial to understand what the underlying conditions are. And so one thing that gives you a sense of this philosophically is relying in the field of critical realism. And it's the idea that mind-dependent aspects of the world that reaches to understand the mind-independent aspects. So we have then phenomena which have real underlying dynamics, which are not readily reducible to simply observed empirical cause and effect. One of the problems, of course, always what we see in the social sciences, we run an econometric or something, we look at the kind of superficial data we have and the cause of effect without really trying to understand what it is underneath it that's driving it, that may not be so quantifiable or empirically evident. And so often we've had this preoccupation with more of a positive approach on the effects of inequality. But the idea is then to go at the very heart of this, of what the causes of inequality, and that one must begin to theorize. We got some of this this morning and other lectures. And so from this, the perspective really says you've got to go beyond epidemiology. You've got to go beyond the surface statistical analysis. We have to look at the wider lens of political economy, which Arup was talking about in quite detail this morning. And here we have to integrate the health effects of inequality with the health effects of racism, sexism, discrimination, the other things that divide our society. Hence, De Maio in this space argues for kind of international political economy and trying to examine, transcend the kind of standard individual focused national level, arguably sometimes a result of neoclassical analysis, to an ontological position, a position which is outside the empirical frame of studies using national databases. And here we have then the issue of the burden of chronic diseases, and the differentiated rising impact on developing countries. And so there's no easy model of understanding that as we carry it from the developed world. And so in some senses, what we have is incredibly an important concept, which I emphasize in my public health courses, which is the enormously differentiated impact of allostatic load. What is that? It's the wear and tear on the human body, which arises from chronic stress. And here you see the examples. A simple one is, the enormously high burden of individuals having to work in a situation where you have high air pollution, high AQI, which just damages, we know, the lungs dramatically. And why does that happen? It's those that can't go indoors and work on their computers. It's the people that constantly have to be outdoors as a result of their socioeconomic position, leading to the long-term health effects on their respiratory system. And this is all very well documented in the medical literature. And it gets to one of my favorite authors, the great, now unfortunately late Paul Farmer, and his idea of structural violence. I got to meet Paul Farmer once. A friend of mine was his professor at Harvard. He came to give a talk in Michigan. I got to shake his hand and talk to him for a few minutes, and I didn't wash my hand for 6 months. I was so excited to see him. No, okay. So he had an extraordinary career. Not only a medical doctor, also somebody deeply involved with understanding the societal, or his famous book on the pathologies of capitalism, the societal dimensions which create the structural violence, which reproduces into the health and morbidity, lifestyle, quality of life of individuals. And it sort of forces the attention to the suffering and injustices that are deeply embedded in the ordinary, taken for granted patterns of the way in the world. And these same structures which render predictable, secure, and comfortable living for some also mar the lives of others through poverty, insecurity, ill health, and violence. One of the things that Paul did, even when he had set up his clinics in Haiti, he always tried to improve the lives of his patients by providing them with decent standard of living through job generation. So these structures, and this is absolutely crucial, so much of neoclassical economic kind of focuses on the naturalism of things. We have to actually then transcend the naturalism to actually understand the histories of the politics, the economics, and social struggles that have created these structures and led to this enormous unevenness. And the thing is, which is absolutely crucial also, is these structures can and should be changed. That has to be, it's in our grasp, we can deal with it. But we have to understand and face what the sources are, the sources of power, the sources of inequality and wealth that generate us. One of my other favorite authors, Coburn, basically kind of follows in the critical realism tradition taking more of a sociological rather than epidemiological position, trying to use political economy. And he does this very interesting empirical conceptual notion of comparing and contrasting neoliberalism and welfare state regimes with enormous implications to the class structure and human well-being with a focus on health outcomes. So you have kind of the standard psychosocial neo-material analysis where you have the social incohesion associated with income inequality, which is manifest through other forms of inequality, leads to differentiation of economic wealth, and then has an effect on health and well-being. And the problem basically is that often income inequality and health correlations are artifactual, meaning the relationship tends to be curvilinear, not linear. So any improvement is automatic or incidental, not causal. It moves with other factors which are transforming. And so basically inequality relationships, including psychosocial, simply due to the correlation with a host of other important social and economic factors that really drive health outcomes, or is there something else actually going on? And so the issue of status hierarchies, but no measurement of self-esteem, as well as too much instability in person's self-esteem over time in this kind of standard model. The problem with the lack of the measurement with this is that the problem is this, is that a lot of chronic diseases take decades to develop, right? There's a latency dimension that in some senses tends to not be explained by the cause and effect relationships that are put into the standard model. It's not simply a sudden reflection of the change of income status. It's something which is developed, such as the differentiated allostatic loads, which take decades to wear down human bodies with the consequences to the quality of life. The relationship likely is not linear, but asymptotic, meaning health and income inequality, with the shapes of varying from country to country, have higher effects of inequality in low income and weaker in high income simply because of the nature of the curvilinear relationship. It's asymptotic. It moves quickly over periods, but is not present in the earlier lower income levels. And his view is we've got to move away from the standard model to a class regime model with a focus on what is called the degree of commodification. And he does some very simple conceptual analysis. So here we have to then look much more deeply on the relationship between globalization, neoliberalism, the power of capital to shape things and to manifest through welfare regimes and markets, the outcome of the various forms of inequality, basically leading to social cohesion and trust, but also numerous social resources being divided up in a differentiated way in terms of education, healthcare, housing, et cetera, leading to the well-being, health, and economic wealth. And so he comes up with what's called the index of decommodification, basically. And it's really, in some senses, a very interesting conceptualization which allows you then to think about the idea of having some kind of standard of living which is independent of your position in the market. That's absolutely crucial because the market really determines what impact it has and what your status is. And it's whether you're employed or unemployed. So in other words, the automatic allocation and access to social goods, and he looks at three very quick programs, pension, sickness, and unemployment benefits, to see if it it actually sets some correlations. Does it actually lead to those outcomes? And of course, what you find very quickly, if you look from 1960 to 1995, an enormous erosion in the position of the countries which are the most neoliberal, United Kingdom, Ireland, United States, Canada, and where their status is relative to the Northern European countries. And so a huge improvement from 1960 to 95 in the rankings in the social democratic countries versus the neoliberal countries. And he goes through and he looks at this decommodification. You find with infant mortality a very strong negative correlation with decommodification, which is higher than anything else, including GDP. The extent to which you decommodify your access to these social goods, to these benefits, leads to the highest improvements in things like infant mortality. And so I will go through quickly. They use other measures like number of people of age 40 and 65. Higher decommodification leads to a rise in those numbers. It's a positive relationship, basically. What we find also is mortality rates and also the sources of PYLL, the sources of disease that kill people before the age of 70. and again, a very strong negative correlation that lowers in the face of decommodification. We see this also with the index of decommodification and the health status in the 8 highest countries with GDP per capita. And again, I don't want to spend time on similar kind of relationships. We can see this also in one of the articles that I signed you on Lynch. And here you have upstream, midstream, and downstream relationships, where at the very top is understanding the role of inequalities of political power, which is absolutely central, socioeconomic inequality and status, and working its way all the way down to the degree of access to health care, including how it affects individual behavioral choices and access to healthy foods. One of the things you find is some terrific literature, which really shows that a very high level of obesity and chronic diseases associated with highly processed foods. And it's the highly processed foods which actually leads to, which is actually today the food of the poor. That's all they can afford is highly processed foods. And so these agro companies are making huge amounts of money with huge consequences to people's health over time. So increasingly you have the chronic diseases as the diseases of poverty. You know, eating white bread, processed grains, you know, things with a lot of sugar, soda pop. And this is all very well documented in the literature. So really terrific patterns where the agro-processing companies worldwide try to transform in the developing world as well the diets of people away from whole grains, fruits, and other things into this diet which is poisonous, you know, and commodified in a way of highly processed with enormous consequences to people's health. I want to then move to the article that I provided on health and wealth inequality, which is looking at what we call the continuum of maternal services. So this is one of the rare studies that I'm able to find in the literature, actually looking in African countries to see, including Uganda, to see, in fact, what factors in terms of the underlying high maternal mortality rate which is related to the accessibility to the continuum of services. And these are kind of fairly simple model in which they have data from household health surveys. And the model kind of very simply looks at of access in terms of antenatal care, in terms of 1 to 4 times, access to birthing facilities, and then your ability to at least once visit, you know, postnatal within roughly 2 days after birth. It's a very simple model. It's very problematic in a lot of ways because it really doesn't look at the quality of the service. I'll talk about that later. You know, but it is, and it's kind of based on some simple World Health Organization recommendations on what should be done. So as we said before, we've had a decline in maternal mortality rate, basically by 34.3% between 2000 and 2020, and the neonatality mortality rate, which is the death rate of infants within a month, which has also declined because of the benefits that accrued. But we know there's a huge differentiation of burden between sub-Saharan Africa and the rest of the world. It's estimated that 70% of global maternal deaths in 2020 were basically in sub-Saharan Africa, which does not have 70% of the population. So there's a massive burden here of the death of women still in childbirth. And so in the region, you're 14 times more likely to die before reaching their 5th birthday than a high income. So it's also manifest in terms of under 5 mortality. So they use these, as I said, demographic and health surveys to analyze the data on maternal health relative to wealth in 16 countries. And what you see here is you see the number of surveys they're able to use. It's significant. It's in the hundreds of thousands. You know, a number of, you know, they're looking at the women included in the study. And then they also give you the very high, basically, maternal mortality rate, which is, of course, exceedingly high in Sierra Leone, but still ridiculously high in all of these countries. You know, 20, 30, 40 times in some cases, 50 times in the case of Sierra Leone, you see in the developed world. And so, as I said, you're looking at the recall in these 3 dimensions of birthing facilities, antenatal care 1 to 4 times visiting, and 1 time within 48 hours in postnatal care, to what they call the continuum of care, which is recommended by the World Health Organization for the safety of the mother and the child. And they then utilize wealth based on the stratification in 5 distinct quintiles, poorest, poorer, medium rich, and the richest. The U's, I don't want to get into the technical details, something called Irigaud's normalized concentration index, which you got to use with binary variables. And you're looking at the range of +1 and -1. Basically, the larger the number, the more that you're seeing the incidence of access to the continuum of healthcare in wealthier people in comparison to the poorer people. So the smaller number, the better you are in terms of actually providing the services for the poor, and a level which is pretty similar to the rich. Okay, and so we have these indexes, and we'll show you the numbers on this. It's always useful to look at what we call the decomposition method. You've got to say, okay, how much is this leading to the outcome of changes in accessibility of this continuum relative to other factors, right? And so for that, they put up wealth against a series of other things. And so they use a kind of generalized linear model of binomial family and probit link, which you have to, whether you're using ones and zeros. And you do a decomposition analysis based on wealth quintile and variables of age, material status, place of residence, educational status parity, and region within the country. So the data, basically, to summarize it, you can see a lot of countries, ANC1, ANC4, these are the two ways of whether you're visiting once or 4 times antenatal clinics, pretty high levels in countries showing up once and diminishing rapidly after for countries like Guinea, only 35% in Guinea, or Ethiopia, 31%, actually go to the rest of the World Health Organization recommended at least 4 times visits to antenatal clinics. And again, enormous differentiations in countries having birthing facilities, and also within PNC2. And then you see what we call the decline, the continuum of care decline, and that gives you in the latter things. What we have is like the drop-off in the continuum of care. Differentiation, how much higher is it relative to others? Very high in some places. And then actually then looking at and comparing the continuum of from basically 1 all the way through to PNC2, or 4 all the way through PNC2, and what the incidence is. So what we have then is at least 1 ANC visit was the lowest in Ethiopia, only 62.3%, followed by Nigeria. Uganda had 98.1%. It was pretty good for 1 visit. And less than half of the women included in the analysis had at least 4. Uganda had a 59.9% of people, of women visiting antenatal clinics 4 times. The percentage of births which took place in health facilities was actually then more than 80% in 8 of the 16 countries. But in 2 countries it was very tiny, Nigeria and Ethiopia. Uganda was at 75.25%. Remember, we don't know about the quality of these. This is a very, very, this is based on individual recollection of this, of women. We don't know really, they haven't gone out and measured where they're going or what kind of care they're getting. We'll talk about that in a minute. And so we saw fewer than half of the women received PNC within 2 days of the birth. The lowest was only 14.4%. In Ethiopia, Uganda was roughly 52.6%. And the percentage of women who completed the primary maternal continuum of care all the way through was highest in South Africa, lowest in Ethiopia. Uganda was somewhere in between, at around 49.9%. And the secondary material continuum, which included recommended 4 antenatal visits, ranged from 8.5%, incredibly tiny in Ethiopia, to 66.2% in South Africa. And Uganda was what I call pretty underwhelming, 33%. So the wealth-based inequality of the continuum was really quite striking between the wealthiest and the poorest, as we see in the figure. So if we look here, we see that at the lower end of the numbers, what we're looking at is the lowest quintile to the highest quintile, huge variations in some countries. You can see between one or the other. But it's kind of curious because the 2 equal ones where it looks pretty similar, actually doing the full continuum of care with the 1 through all the way to the antenatal, was actually pretty even in Sierra Leone, in South Africa, and one having the lowest level of maternal mortality, one having the highest, but they both had equal care. So it tells you there's something missing here, right, guys? Okay, and we'll talk about that. So there was a statistically significant pro-rich inequality when we look at the data and break it down in the primary maternal continuum of care, basically. The concentration indices were 0.05, which is pretty damn good in South Africa, and also in Liberia, and 0.34 in Nigeria, which by far had the most unequal. The second highest inequality was in Benin. Uganda was somewhere in the middle with a concentration index of roughly 0.14. And the secondary maternal continuum had similar results. You can see this where it shows up with the graph, and of course you always got the confidence interval of the statistics, and that gives you the range of the confidence interval where it could possibly be within the 95% margins. The decomposition analysis showed that, in fact, that wealth index was the largest contributor to inequality and primary maternal continuum of care in 15 of the 16 countries. So wealth is a big driver here of inequality, of maternal care. That's an important analysis. Again, it's always good to think about it conceptually. It's also really good to get data and see if it shows up relative to your hypotheses. This is something which always then empowers your analysis and your data and the feedback. And so basically what you then had was education, the second highest in 7 countries, administrative region in 6 of the countries. So again, what do we make of this high level of continuum, low concentration rates of Sierra Leone versus South Africa? Where Sierra Leone having the poorest health system, and South Africa the other. The one thing they have in common, not surprisingly, is public care systems. And so what we had is the Free Healthcare Initiative in Sierra Leone, which reduced the barriers for those with little wealth to get access, basically. And though this was not discussed in the article, you look at what happened in South Africa. Well, South Africa actually has very high levels of a series of publicly supported free programs which allow universal access both to information. They have an information system. Any pregnant woman can actually, with their phone, link and find somebody to talk to if they're having problems. But also, prenatal care was provided for free to all pregnant women in health clinics. And there was a bit of a battle always in South Africa, who gets what. It went to the courts. And in 2023, the court said, every pregnant and lactating woman in South Africa should have free access to public health clinics. And so it made a difference. It's been there for a while. They pushed back on it. Some of these neoliberals wanted to push maybe more privatization, differentiation, raising fees. And the court said, no, everybody gets access. And so that really explains the differentiation. But of course, the big difference here is an enormous variation in the quality of the care which is provided in Sierra Leone, basically. And so, but it does lead and begins to show some prima facie evidence that, in fact, the whole nature of accessibility is very much determined by the system that is there. We saw that with the hinting of that with the index of decommodification, with Colburn's work. We see this in the data as it comes out in the 16 countries in South Africa. And so, and there's a quote basically, from the study, which says, financial protection plays a key role in achieving universal health care, including for maternal health. Accordingly, countries with very low health insurance coverage, low health care use, and high out-of-pocket payments such as Angola, Burundi, Cameroon, Nigeria, oh yes, and Uganda, must revisit the financing of maternal health services. And so it really gets into the final point about the need for universal access. We've known this for a long time, right? But the problem is this neoliberal period, and the heinous impact of the work of the World Bank. If you'll see the chapter I wrote in my book, Beyond the World Bank Agenda, really highlighting the absolutely flawed analysis from this neoclassical economist that led to the user fees on financing healthcare. This guy by the name of De Ferrante, who, of course, what did he do his PhD on, this economist? The horrid impact of welfare support in the United States. So the guy was a right-wing ideologue, came in, worked for the World Bank, and came up with the most, you'll see that I sarcastically rip it apart, the nonsense in it. At some point, De Ferrante was quoted in saying, maybe today I wouldn't take the same position, but I don't regret taking that. And so basically what happened was that we go back to the history of this. There's this good article, which I also assigned in February 2003 in the very good journal Social Science and Medicine, which actually lays out this kind of issue, the discussion of health for all on historical and conceptual issues. And they point out how much the fault lines of socioeconomics were exposed by the pandemic. It's something that I've written on as well, which really was embedded in the injustices of race, class, gender, and geography, manifesting in who got sick, who died, and who was vulnerable. It illustrated in some senses our enormous distance from achieving health care for all, exposing the glaring inadequacies of the health systems. The origin, if you go back to it, and on the history of it, you go back in the Universal Declaration of Human Rights, which was passed by the UN General Assembly in 1948, it said simply, everyone has a right to a standard of living adequate for the health and well-being of himself and his family, very sexist in those days, including food, clothing, housing, medical care, and necessary social sciences. The Hugh Constitution in 1946 asserted healthcare was a basic right irrespective of race, religion, political belief, and governments had a responsibility to assure the health of the population. And so although the world has amnesia, we had this wonderful conference in 1978, 143 countries came committed to the goal of providing universal primary health care. And so over time, unfortunately, it had little or no traction in the United States, basically, other than places in Europe, in Northern Europe, and a long history both in reality and in political rhetoric. I mean, you look at the United States with its horrible outcomes, it has by far the worst indicators of health in the entire developed world. You know, with high, really falling life expectancies, incredibly high infant mortality. It goes across the board, right? And it has a system which is almost entirely based on the market, with huge consequences. And the cost is unbelievable. I remember having a very bad asthma attack in 2008. I spent the day in the emergency room. My bill for the day was, you get this, guys, $20,000. Fortunately, I had health insurance through the university. I wouldn't have afforded anything after that. I would have had to gone into enormous debt. You know, and you see this happening with people that don't have access to insurance. And of course, up to the Obama Act, the Affordable Health Act in the United States, they actually were able to, insurance companies, deny you any support if you had a pre-existing condition. It's insanity, the system in the United States. You know, and so basically, the key question is to identify the exclusion, limits, and frictions to the concept. And so some argue that capitalist society itself is structured basically, which making egalitarianism and inclusion at odds with the profit-making, inequality, and class division. The reality has also been against the demands for efficiency and marketization, basically more recently, who isn't a citizen. We find this in the United States, the screaming from the, and I'll say it quite clearly, the fascist MAGA party, they are a fascist party, guys, you know, talking about, you know, providing health care to non-citizens or illegal citizens. And of course, it's stupid because from a basic public health issue, you need to provide protection for everybody because protecting one person protects everybody else. It's the complete inanity, of course. We all know that the dear President of the United States, you know, basically said, you just got to drink a little bleach to get rid of your COVID, you know. That'll solve everything, you know. He didn't listen to his own idea, but, yeah, but in any case, this is where we're dealing with this enormously anti-science position leading others this kind of ideology, this demonization, the otherness, I mean, the utilization of Hitler-type metaphors of the poisoning of the blood of Americans, of immigrants coming in. It's just outrageous. Anyway, okay, off of my editorial, you know, stool here. So basically, the debate on the meaning of primary care with government in developing countries basically was all about not addressing basic needs like health care, housing, and nutrition. We go back to the World Development Report. As some of you perhaps know, I'm kind of a close watcher and writer of what the mischief the World Bank has gotten into over time. And so in 1980, in its background paper on health policy, the World Bank actually supported Alma-Ata Declaration, focused on the need to address health inequalities between developed and developing countries and a goal of universal access to primary health care. So primary health care is then addressed the main health problems in the community aimed at providing a basic group of services of preventive, promotion, curative, and rehabilitative services. And the key players in Africa, of course, has always been the World Bank. And so their World Bank Health Agenda, they believed education concerning prevailing health problem was important at preventing, controlling them, promotion of food supply, proper nutrition, adequate supply of safe water and basic sanitation, maternal and child health care, immunization against infectious diseases, prevention and control of endemic diseases, appropriate treatment of common diseases, provision of essential drugs. And then they had the main background paper. I'm one of these crazy guys that reads all the background papers of the World Bank, which often leads to pulling my hair out. Fortunately, I still have a lot of it, so otherwise I would have nothing. Because the stupidity of what they write in some cases, just, you know, it's not only the user fees, the idea that they wrote in education that Africa really doesn't need higher education. Yes, guys, that's what they wrote, with enormous consequences and follow through with policy, with the structural adjustment period. And so they did, though, you know, progressively, standing behind 1980, just before the era of the structural adjustment madness. They believed, yes, in the paper, health is a human right. Health through the reduction of morbidity and mortality in population should be a core of the development process, and it's seen as the base of improvements in morbidity. Community participation was very important, basically, in a dimension of low-cost health care. People had both the right and duty to be involved in planning and implementation of health care. Health care planning should incorporate all possible activities which can improve health care. You know, health interventions such as relation with nutrition, infection, and disease are very synergetic. And health basically should be primary health affordable, socially acceptable, basically away from simply high technical solutions, but providing a basic set of auxiliary workers and health solutions that everybody could have access to. The paper actually wrote, believe it or not, the use of prices and markets to allocate health care is generally not desirable. But by 1985, with the Ferranti paper, that's all they did, is they talked about the impact of user fees and prices on basic public health, with a heavy promotion using neoclassic economics, that, you know, they made this absolutely insane position that, okay, you know, from the perspective of the lack of information, maybe you can support a little preventative health, but with curative diseases, everybody knows what they have, and they'll simply be willing to pay what they need to pay to cure themselves. You talk about the insanity of that. Like, you know, you don't need a doctor. I know what I have, right? and you know, and hence I'd be willing to pay for it. I mean, it was just, you know, I would have thought when my child was 5 years old, they could have actually contested that. But no, I'm not sure, Daddy. I have a fever. What's the cause? Anyway, so basically then, increasingly healthcare under the pressure of the World Bank pushed commodification, not a right to be delivered by governments. More recently, heavily pushing private partnerships, NGOs, philanthropy in the market, anything but the public sector. Example basic of the contradictions in seeing universal health care coverage agenda more recently, where they're kind of rediscovering the importance of this, you know, and that dominated, in their view, the idea of health for all. And so they promoted by the World Health Organization, which sometimes, unfortunately, gets sucked into these neoclassical arguments in the World Bank, and was incorporated as sustainable development goals that the universal health coverage proposes a situation where everyone has access to the health care they need without suffering financial hardship. Question is, how the hell do you measure that? It's a slippery slope. It was the idea also of the stupidity in the thinking of the user fee model, of the idea that you could differentiate the notion of what you're willing to pay and and your ability to pay, as if you can actually know this. You know, and we know, of course, in the case of Africa and other poor countries, when you introduce user fees, the opportunity cost, you get these idiot neoclassicals saying, you know, I have this job at the university. I should be paid a lot of money because of my opportunity costs. I could earn in the private sector this amount of money. Hence, I should have the highest salaries at the university. And they made the same argument for poor people. You know, you have to wait. It's your time waiting with the public sector. You'd be willing to pay user fees to provide better services because, you know, that way you'd be compensated. And of course, the stupidity of it is the basic, in very cash-poor families, and we see this over and over again in our interviews, you know, the opportunity cost was not my time. You know, I could be sitting around and enjoying myself or earning money, and hence I'm willing to pay to lower the amount of time of waiting. No, the opportunity cost was, you know, food versus healthcare, or, you know, education versus healthcare. And so all of this stupidity of these neoclassicals in their thinking on healthcare, with enormous consequences to the livelihoods and the welfare of people in the poor countries in which they had the asymmetries of power to impose this ridiculous conditionality. And so that, of course, gives them the slippery slope. Key phrases, financial hardship, neatly skirting the issue of free subsidized and primary health care, which you don't mention. You know, and, you know, it seemed on the surface, okay, maybe they're actually then going beyond the neoliberal interpretations of healthcare in the global south, basically, but the reality was, of course, a continued marketization. And the overwhelming approach has increasingly been PPP, which is, of course, private-public partnerships, stating only can help the poor by subsidizing the private sector. So it really wasn't a transformation. It was a kind of surface appearances that we're trying to do something else, but actually pushing the same privatization and commodification agenda. And so what we have then, while universal imaginaries as well as expansive programs and infrastructure technologies have really been central attempts to realize health for all across the globe from the 1950s to the present, not all individual communities, obviously, have been included equally in such attempts. On the contrary, they argue, Carol, exclusion, blind spots, marginalization, and thus the absence of healthcare persists in many places and are the focus of remaining contributions, they argue, in the special issue they put together. Such exclusions and marginalizations along lines of race, ethnicity, class, and wealth, gender, often encoded in universal policies and programs, nevertheless favor certain individuals and groups over others. The larger question, of course, for our common future remains whether it's at all possible to achieve egalitarian systems of accessing, giving, and receiving health care fundamental to our collective well-being within a capitalist, neoliberal, and neocolonial system. The question remains, of course, open. Health for all both implies and requires continuous political struggle and aspirations of health for all, and it's always been tied to the political questions about the kinds of societies we wish to live in, and hence the inequalities have persisted. Of course, embedded in that is the, as I talked about earlier, in the global system, the enormous asymmetries of power, the ability in the financial system to constantly leave African countries susceptible to crisis financially, having to rely on the conditionality imposed by the World Bank historically and the IMF and the donors in periods of crisis, getting their way. And one of the things you, for example, find, in the latest crisis, one of the things I do is I write on these things. We just published an article on the debt crisis in Zambia, and you have a long list of the neoliberal wish list. One thing, of course, they did is they said the government has to improve the independence of the central bank, and there were also issues of trying to create privatizations and greater private-public partnerships. And so, in essence, the neo-materialist approach points to the multiplicity of challenges that are involved. So let me conclude here and say, basically, the neo-material interpretation is really an explicit recognition that political and economic processes generate inequality, and it also influences the way in which individuals access food, water, and housing security. And so what we have is a need for strategic investments in neo-material conditions, basically marketable distribution of public and private resources, but it's also understanding the underlying political economy interventions and necessity for political struggle. Nothing is going to come otherwise. Psychosocial elements are still there, and there's a good study I used to teach in my class by Kagman, an empirical study, which showed that perceptions of inferiority and low status do have an impact. But when the higher income groups get richer, they may disconnect from the community, and lower income groups may perceive the world to be unfair, unjust, with psychosocial responsible individuals, so the perception of their place in status ladder detrimental to their health conditions. And so in essence, then, you can see social status manifesting all the way through level of hormones and behaviors, withdrawal, apathy, hypervigilance. Societies with low income inequalities now are able to deploy the resources to collectively tackle risks such as pollution, traffic congestion, crime, leading to improvements in well-being. So we basically say from all the studies above is not only we have to think about the material conditions, we also have to think of the psychosocial conditions and mental responsibilities and understand the underlying conditions that generate the inequality and its reproduction in our current world and the system that actually perpetuates that. Let me stop there. Thank you.
All right. Thank you very much, Howard. And the room is open for questions. We have two right there. Could you?
Yeah, thank you very much, Howard. Mine is about this theory called the health-seeking behavior. With the health-seeking behavior, we expect that members of our community to be able to access healthcare and probably get better. And then, of course, when we relate this to life expectancy, as you mentioned, I wanted to look at, for instance, Europe, maybe as Jacob the other day mentioned, a democratic, welfare state. Our system here, you already mentioned that we need to improve the health system so that maybe our life expectancy can really get better. But you find that the health-seeking behavior, for instance, if you mention the issue of measuring the latency of our sicknesses, so you find that many of us, we have a lot of diseases afflicting us without knowing. And essentially, people can just die like that without simply knowing that somebody has been actually hosting a disease. So I like some explanation how these the health system in relation to, for instance, as you mentioned, the new materialist approaches or interpretation in that sense can actually be improved so that this, discrepancy in our healthcare or our health can actually be improved. Thank you.
Thanks very much for such a great presentation that also centers wealth in the understanding of health equity. When you were talking about the big actors such as the World Bank, I was just wondering perhaps if you could also comment on now the new set of actors that operate in a very similar, if not more aggressive paradigm, that of the philanthrocapitalists, such as the Gates Foundation. They've come out quite explicitly to say they don't believe in public health systems. They've skewed a lot of, through their agreements, they've skewed a lot of funding towards what they view as priorities rather than priorities that may be prioritized by the local health authorities. And they've also encouraged a decentralization of power when it comes to pharmaceuticals. So, yeah, I'd be interested in your thoughts on that.
Do we have a third question? Yeah, in the back.
Thank you so much for your presentation. I want to hear your view on situation in Africa where a good number of people are seeking health solutions from traditional birth attendants. And lastly, if there could be any success story on cost sharing in health sector in the world, you can share with us. Thank you.
First, over to you, Howard, and then we'll take more questions.
All right, let me respond to three very good questions. Basically, one is able to study the underlying vulnerabilities that are created over a lifetime. We get more understanding of this at times. If somebody picks up an infectious disease in an early stage, there could be chronic disease implications later, many decades later, because of the impact that it has. And really the crucial thing is understanding what I call basically the kind of life analysis of understanding where the vulnerabilities are at different points in time. And studying back, somebody comes up with a disease. Part of it has been to actually then interviewing what's happened over their life to see, in fact, are there patterns they can begin to identify which are the causes, and then begin to actually then address interventions to deal with the disease over time. And so it's taken a long time. Part of the big problem, as you know, is that takes research and innovative research and open-mindedness. What we have in a world is one in which we are overwhelmed by way too much power to pharmaceutical companies. And the pharmaceutical companies are all about focusing on the issue of, here's a pill, here, and this will cure it. But then it also leads to these side effects. You better take this other pill, so that can be curing it. And of course, for the most part, the pharmaceutical companies have no interest in curing anything. Where the incentive is creating a long stream commitment to using a drug over their lifetime to stay alive. And that's one of the reasons why we had such great investment in HIV, because they could turn HIV into a chronic disease where you're on these pills your entire life. And that's a great long-term generation of income. And of course, you have your first level interventions, and when that doesn't work, well, we can charge a lot more for the second level interventions if you want to survive, and the third levels. And so it's a disgraceful system based on the market incentives. The worst is the United States that doesn't even put any price controls on anything. So they can charge what they want. So, these new drugs to get rid of obesity, they're tens of thousands of dollars a month. And it's the same with these other products. It's out of control completely. And we know that, for example, I found myself a wonderful physician who actually uses a multiplicity of different interventions. And one of the things we know, for example, I have asthma. It was acting up. And I said, well, what caused this? It wasn't bothering me for a number of years. And what it really was in fact the lack of nutrition, different nutritional elements. It was a change in the nature of a biome, But, pharmaceutical companies can't make money off of that. So nobody does the research. And so it's absolutely central. We change the nature of our research and understanding of what the causes are over time and how to address them. Increasingly, we know that understanding the balance of bacteria, in your biome really tells you a lot about your health and can be directly intervened with all sorts of approaches, So my physician did research on a particular, probiotic, which actually lowered cholesterol levels. So I'm taking it. And he showed he's a complete scientist, but he thinks outside the box. And so this is part of the issue. We have to change away not just our understanding and treatment of disease, but the kind of research that creates prevention and understands where early interventions can dramatically improve the lifestyle and reduce morbidity. It's there. We know it's there. We've studied this over time. But it really means kind of expanding our horizons, not only to move away from pharmaceutical companies saying, oh, well, what impact this has, to actually looking at the complexity of what creates a healthy human being and where that's lacking in every society, and what bacterium and what parasites where people come into contact with things leads to long-term consequences of health in Africa, And so the research has to be done. But like in economics, you got to think outside the box. You have to open your mind. You have to use different tools. You can't be stuck in a dogma, where all the incentives are to play the game and the rules that are being created. I could go on a great length about this, the metaphors. Now, Rupa, I think you raised an absolutely central issue. The big elephant in the room, everybody says, isn't it wonderful? Bill Gates is giving all this money to healthcare. But Bill Gates at the same time is a market guy and interested in expanding the market. I don't know if you guys, but they used to, I took a group of students in 2007 to do a study in Mwanza at the impact of diarrhea in relationship to poverty, right? Including a medical doctor from Japan. They went and studied the relationships and the sources and who was getting good water, who wasn't, et cetera, et cetera. But, we discovered that we visited these two main centers, and you have this kind of medical institute in Tanzania funded by the Gates Foundation. And these guys were living in, they had, the latest vehicles, air-conditioned offices, latest computers, right, in their offices. And they were, sarcastically, we used to call it the ATM. Why an ATM is like a machine, right, a cash machine? Well, the ATMs, what are we referring to? AIDS, tuberculosis, and malaria. And so all the other diseases and we decided to study diarrhea. Well, diarrhea kills children a lot more than those 3 diseases, but it's an orphan disease because Gates came along and said, well, this is what's important. And part of it is Gates tried to push technological solutions that could be addressed through the market rather than public health solutions, actually push things away. And so Gates is the elephant in the room, which has had a disgraceful impact on public health. Now, as Oswaldo was saying, am I ever going to get funding from Gates? No. But it wouldn't happen anyway. So I'll be open and say that we need to be very critical of the enormous and really peculiar, really in some senses, the enormous unevenness that is created when it's driven by a group which has so much money. It's a huge issue. I mean, look, we can see it. This crazy, apartheid-raised neo-fascist mosque. Whoops, they'll come after me for this comment. But, he buys X, and starts putting all this nonsense on, spends huge amounts of money on, distorts the world as a result of reproducing disinformation. And we have far too concentrations of wealth, which are manifest in generating peculiar, basically types of outcomes, which are very problematic for human lives. And that's one of the things, we need to talk about here as well, is really the enormously problematic nature of the spillover effect of this concentration of wealth. Gates is worth, Musk is worth today, they say, $1 trillion. What kind of insanity we have in a world that allows one person to have $1 trillion and to go out and spend it the way he wants to, It's just, pushing now this character Trump, with all this disinformation. It's a maddeningly problematic situation, and it is a direct result of the concentration of wealth, which gets more and more extreme, basically. And then it gets back to this final issue of midwifery, and there are good research on that. I mean, part of the issue, of course, is quality of assistance in medical care. I teach and assign quite a bit of articles in midwifery. You can have a really, really high level of midwifery training and provide that, and a comparatively inexpensive availability. Part of the problem, of course, is sometimes there's complications that exist, and part of the issue, of course, is young women, which would, getting pregnant, the importance of maintaining and avoiding pregnancy and getting early marriage for women that are not heavily fully matured bodies is extraordinarily problematic. And it's so you always need to have some facilities available to deal with complications. But for normal births, midwifery, actually, properly trained midwives can have a very positive impact. We have a lot of data on this, in certain countries where we've been able to advance it. I'll stop there. As you know, as an economist, I also love talking about health. My ex-wife used to say, "What are you being an economist for? Go to medical school, It's really where you should be." Anyway, let me stop there. She was a doctor, by the way.
Thank you, Howard. I think as we're approaching 4 o'clock, we might have time for one last question, but then unfortunately we have to wrap it up. And again, you can ask Howard afterwards if you have any remaining questions. So I don't know who gets to ask the final. All right.
Okay. Thank you, Prof, for the fascinating presentation. In fact, mine is a comment. I do believe that good health is wealth, and for Sustainable Development Goal 3, that is inclusive healthcare, to be achieved, we have to put into account of SDG 4, that's about inclusive education. Because people do talk about people dying of unknown diseases and decreased life expectancy, specifically in Africa, or if I'm to go specific. And I think this one is equated to illiteracy or wealth inequality. For example, when I talk about maybe periodical body checkup, some people might fail because of wealth inequality or illiteracy, because there are some people out there who have money, but they don't know that they're supposed to go for periodical checkups. So I'm of a view that for SDG 3 to be achieved, you have to put into account of SDG 4. Thank you.
So I think what you're arguing basically is the importance of education, understanding, and absolutely central among all groups. But that's also part of. It's not just the understanding; it's the equity of that understanding. If we have a system of private education, then the quality of the education is enormously differentiated, and people then are not given the full tools to understand the nature of medicine. Really, every person should be their own best doctor, and reading up and finding out about that. But you need that education to be able to do it. If you look at an article, you need to be able to understand how statistics work, what the implications are. So I completely agree with you. I will make one very quick comment, my editorial comment. As you know, I kind of like hard-hitting Howard likes to make editorial comments. Okay, so we look at one editorial comment, Sustainable Development Goals. They're very problematic. Why are they problematic? Because we're looking at surface goals, and it does not really move to understanding what is this system that has created these conditions. And how do we address that system to be able to deal with it? What are the embedded power structures that have created enormous inequities with all these goals? And so it really becomes this issue, and it's one of the reasons why money and development goals were such a lack of success, because it's always about talking the surface appearances, as I talked about, rather than going to the deep, critical, realistic understanding of what is actually driving these inequities, and how do we address and deal with it. And that becomes really important as we study from so many different dimensions here in this school, is the issue of inequality and how incredibly important it is in understanding the system that has created and manifested in these gross inequities in all sorts of levels, including healthcare. So let me stop there. That's my final editorial comment. I'm done. I'm only doing 3 talks. And I'll look forward to listening to your continuing very fascinating questions, and interventions, and the rest of the lectures. Thank you very much.
Another round of applause for Howard. So I think now we're supposed to do the allocation of groups for the blog posts, but I think unfortunately Jacob, who lost his jacket yesterday, is currently still trying to get back his jacket, so he's not here yet. So I would suggest maybe that we take a really quick break. So really just, do you know if there's tea? Okay, but otherwise let's just take 5 to 10 minutes, but let's also try to, when Jacob comes back, really try to start, because we want to finish at 5 so you can all go home and rest a bit before tomorrow. So I think in your agenda it says that Emmanuel Sully was supposed to present today, but Emmanuel's flight got cancelled, so he's only arriving tomorrow and then ready to hold his talk on Saturday. There will be a final agenda which I've just tried to kind of put together and send to Resti for you available, so you can see like the definite plan for the last couple of days.
Yes, Paul. There is no tea yet, so.
Okay. All right, everyone. To get them into the room, or what? It's just about like what I'm trying to do is we're trying to do a poll on Google Forms basically where everybody can choose a topic of their liking, and then based on that we'll allocate the groups. Yeah, and anybody who doesn't have a device to scan it can just come up here and I'll do it manually for them. I think we should start, right? Okay, everyone. It seems that I think Jacob is not coming back in time, and I don't want to make you stay here until after 5 p.m. So I'll just try to do this myself. Could you put up the presentation on the screen? Sorry? Could you put up the... perfect, that's it. I can't see the whole of it, but it should be fine. So the idea, like I tried to go through all the questions that all of you put on the board yesterday, which was a very impressive amount and also very impressive variety. And as we said, what we're trying to do is to form groups of, say, 4 people, around 4, it can be 3, it can be 5, but in that area. And these groups should consist of people who have a similar interest, like in what to work on this blog post. And since we had, I think, above 100 questions, I try to not list each of them individually, but try to form groups out of different questions that have similar character. So what you could just see here, but now not anymore. Could you switch back? It's basically, I think there's 18 groups. Part of them you can't see down below. Roughly kind of categorized by topic. And since we're quite many people, it's, I think, not all too easy to now form groups. So what we're trying to do is we've made a Google Forms kind of poll, where you can go to using your devices. If anybody in this room does not have a device that can scan a QR code, you can come to me and we can manually put it in, or I can also show you the link and then we put it in. And yeah. Is it possible to, or maybe I can just move it up. Wait a second. This also works. So anybody who has a mobile phone or a smartphone could just scan this QR code. Anybody who doesn't can come to me once I'm finished, and then I'll just put in your name and whatever you like the most. Huh? It works now? Yeah. Is it actually?
Paul, actually, if you have a smartphone and you have Wi-Fi, you can just go to Google Play and just download a QR code scanner. It's pretty easy to take under a minute if you have good internet.
Perfect, thank you. And you just said that you had to... so maybe
another way to do it, you can just go to settings if you have an Apple phone, because that's what, or any other phone. Google settings. Sorry, you can go to your phone settings, then you go to your camera, then activate QR code. Then after activating your QR code, you will just use your camera and it will immediately work.
Thank you.
So somebody just informed me that you actually needed to log into a Google account to do it, so I'm quickly trying to change that. But are there any questions about this procedure? Or anybody who does not understand how it works? Yeah, I can also put it up, the link. Yeah. Jetzt soll es gehen. Kannst du nochmal probieren? Achso, du bist angemeldet. Kannst du nochmal versuchen? Weil jetzt sollte es eigentlich gehen. All right, so now it should work without logging into Google. Maybe if you try to go on camera, and then just go on top of it. Yeah, okay. And just hold it onto the QR code like the camera. I'm not sure if it works now. I'll help you in a minute. So let's just quickly, for those who have already made it to the form, this is what it looks like. You have 18 questions. You see, like these are the categories that are formed based on your questions. And I've also listed the various questions that fell under this category here. So if you scroll down, you have 18 different options of responding, and they all say either interested or not me. And what I would ask you to do is, for one, to add your name here. It's at the very top. You can just enter your name. And then below, choose whatever topic you are most interested in, and just click on interested on one of these topics. You may click on not me on the others, but it doesn't matter. The important thing is that you find one category, one topic, like, for example, land policies, and you choose it by clicking onto interested. And then that's all you have to do. So, yeah, for example, now Moritz did it. He entered his name here. And then in this case, he clicked not me on all those he was not interested in. And yeah, interested on the one he was interested in. So whoever needs help, let's just try to, for anybody who can help with these matters, let's just go around, also maybe the German students here, because I think then we'll get it done. Just one. Yeah. Huh? Yeah, please only choose one, because then afterwards we will take your vote and just put you into that category. And if there's, say, 8 people in one category, we just do 2 groups out of that category. So just click like answer for one topic, the one that you are most interested in. And I just heard that there's actually a WhatsApp group that all of you are part of. Is that right? Resti, do you have a WhatsApp group with all the people in here? No, we can create the email. It's a bit of a chaos because
Was funktioniert nicht? Das QR-Code.
die meisten haben einfach keine Smartphones oder wissen nicht, wie man einen QR-Code scannt.
Okay, ja. Und dann können wir ja den Link, schickst mir den Link, dann gehen wir.
Ja. It's here. So here's the link, but I don't know how to give it to people because it's up here it is. Yeah, it's quite hard to.
Do you have Facebook, WhatsApp here?
Yeah, WhatsApp here on. Yeah, I'll put it up again. Let me quickly put it. Ja. Ja, aber sonst musst du dich anmelden, wenn man das ausschalten will. Wenn man. Hä? Ja, du kannst noch mit einem anderen Namen. So, anybody who has trouble with this can also just come to me, to Jacob, or to anyone here, and then we'll enter your choice for you. It goes very quick because we have access to it, and then we can just enter your name. Yeah.
I need your support here.
If it doesn't work here, I can just enter your name for you.
Okay.
Like, let me do it like that. I will put up the list, and then you just tell me which group you like best. And then, give me 1 second. I'm gonna. Let's just quickly find it. Give me 1 second. You can do it on my laptop. Come here, you do it on my laptop. So, you see, these are the topics, and you just tell me which one you like best. Gender? Alright, you've decided, perfect. So, gender, interested, and then you tell me your name.
What the Francis?
Yeah, can you put it in, and then...
Anyone needs help?
Yeah, who needs help? Whoever needs help can come here or to Jacob, and we'll just put in your name for you. You don't need your phone, you don't need your laptop. We can just quickly do it for you. Apologies for this being a bit chaotic. If anyone else still needs to put in their name, just come up to me or raise your hand, I'll come to you, and then we can enter it. How's it looking for everyone? Is there anyone who still needs help? Bless you.